Hello, everybody, and welcome back to Emergency Medicine Quest. In today's video, we will be discussing about heart failure. We're changing things around a bit, so please bear with us. Before we continue, make sure to like, share, and subscribe to the channel for more such content. Definition wise, we know that heart failure is a clinical syndrome in which we have depressed cardiac output. We have signs and symptoms that go with this depressed cardiac output, like dyspnea, edema, fatigue, exertional intolerance. Any heart failure that comes to the ED is by definition an acute heart failure. Acute heart failure can be divided into two categories. So we can either have decompensated chronic heart failure, or we can have de novo, which means basically somebody getting newly diagnosed as a heart failure. Previously, when we used to classify heart failure, we used to classify it as systolic heart failure, diastolic heart failure, congestive heart failure. But nowadays, these terms are labeled misleading. So, what we prefer to classify our heart failure into as is, does the patient have a reduced ejection fraction, that is ejection fraction of less than 40%? Is it mid-range ejection fraction, that is from 40 to 50%? Or is it preserved, in which case it's going to be ejection fraction more than 50%? Moving on to pathophysiology, so let's get a bit of background to understand heart failure better. So, basically, the pathophysiology is explained by this formula, which is cardiac output is equal to heart rate into stroke volume. Now, we know that stroke volume itself is end diastolic volume into ejection fraction. So, we can write it as heart rate into EDV into EF. Now, it's important that we give terminologies to this equation because we have medications that work on each of these. So, we have heart rate, which is basically chronotropy. We have EDV, or end diastolic volume, which is lusotropy. And then we have ejection fraction, which is inotropy. Now, you might remember this graph, which is called as Frank-Starling curve. And basically, what it did was it plots your stroke volume against end diastolic volume. And generally, we should see a curve like this. If the contractility is going to be higher, then the curve is going to be above this normal line. And if the contractility is going to be lower, then it's going to be below. But the idea is that the curve is going to remain the same. Now, we notice that there is only so much of a point that if you increase the end diastolic volume, will your stroke volume increase? Will come a point, a plateaued point almost, where no matter how much you increase the end diastolic volume, the systolic volume will remain the same, right? And this is basically the point where if you increase your end diastolic volume, the stroke volume does not get affected and the sarcomeres start to get stretched, and they basically get themselves aligned abnormally, and after a point it can also cause systolic dysfunction. So repeated increase exposure to increase end diastolic volume can cause myocardial hypertrophy, because as I said, the sarcomeres keep rearranging themselves, and it can lead to a stiff, non compliant heart. Now, if we go back to our equation of cardiac output is equal to heart rate into stroke volume, technically, if the stroke volume comes down, which it does in heart failure, then we can compensate our cardiac output and keep up with it if we increase the chronotropy or the heart rate. However, we should be aware that if a person comes with persistent sinus tachycardia and they have a background of heart failure or acute decompensated heart failure, then this is a very ominous sign that our cardiac output is basically maxed out. And we need to, this is also what explains, and this is what we need to understand, that any irregularities in the heart, whether it's a tachyarrhythmia or a bradyarrhythmia, can basically tip a person in heart failure to acute decompensated heart failure. Now, patients with chronic heart failure tend to have their Frank Sterling curve somewhere close to this because of chronically impaired diastolic function. All major classes of acute heart failure therapies work by targeting this curve. What they are aiming to do is basically either move this curve left and up. So it tries to move it left with drugs like diuretics, and it tries to move it up with drugs like inotropes. One more aspect of pathophysiology in heart failure that we should be aware of is something known as cardiorenal syndrome. Basically, it is worsening renal function due to acute heart failure, and acute cardiorenal syndrome occurs in about 40% of the cases with heart failure. How we should suspect cardiorenal is if there is requirement of higher doses of diuretic per amount of urine output. And ideally, the way we manage cardiorenal is also to give a high dose of diuretics, or you can combine it with a non-loop diuretic. Now, giving high doses of diuretic is something that a clinician is generally quite wary of, because they think that the creatinine rise will get worsened with the use of IV diuretics. But research has shown that creatinine rise after the use of IV diuretics in acute heart failure is not associated with any true renal tubular damage, and it is not associated with any worse outcomes as well. As for the clinical features of heart failure, we know that the most common symptom is actually dyspnea. And as for the most common physical examination, then it is peripheral edema. There are other findings also like jugular venous distension, rales, S3, murmur. If we talk about ECGs, then the most common precipitant arrhythmia is AF. So now that we're talking about precipitants, let's understand the first most common cause or the most common precipitant is medication or dietary non-adherence, followed by ischemia, infection, or any arrhythmias. If we move on to the diagnostic test and tools for heart failure, number one, obviously, we can run always an ECG. This is to see for any signs of ischemia or any arrhythmias. We can do a chest x ray. Now, generally, a chest x ray is going to show the classic signs that we're all taught about, that is, pulmonary edema, cephalization, curly B lines. Remember that chest x ray in itself is a good tool, but chest x ray combined with the clinician's gestalt can solidify a diagnosis of acute heart failure. As for the lab testing, so we can do a complete blood count to look for any infection or any anemia. Anemia is going to be present in heart failure patients, especially those who've had heart failure chronically as anemia of the chronic disease. We can also do electrolytes. Now, there is one electrolyte that deserves special mention, and that is sodium. Remember that sodium is generally associated with worse prognosis, and it is a predictor of all cause mortality in acute heart failure. The third test that we should send for is a trop. Now, trop can be obtained and trended if either it becomes elevated or if we suspect that the patient is having underlying ACS. Elevated troponin is also associated with increased mortality. The next test and the most talked about test probably is a BNP. So, a BNP level of less than 100 nanograms per liter, or NT pro BNP less than 300 nanograms per liter virtually rules out acute heart failure. But there's a caveat if the BNP is above these values. First, that BNP can falsely decrease in cases of obesity, and it can falsely increase in cases of CKD. So, as a general rule of thumb, the idea is that we half the BNP in CKD patients and we double it in obesity patients. The final test that's worth mentioning is basically lung ultrasound, especially with the rise of ultrasound in ED department. Lung ultrasound for heart failure is basically considered positive if we have three or more B lines on one side. Moving on to the management of acute heart failure. So, we manage it just like any other emergency. We'll assess our ABCs. So, are we suspecting acute heart failure? If yes, then is there any respiratory failure or increased work of breathing? If there is, then we start them on non invasive ventilation. But if they don't tolerate non invasive ventilation, or if there is any contraindication to it, then we can also consider high flow nasal cannula. If there is no respiratory failure, then we have to look at what is the hemodynamic phenotype of this heart failure. And it's important because we will be managing heart failure according to that. Is the person in cardiogenic shock? That means their blood pressure is going to be less than 90s. Are they in the cardiac phenotype of heart failure, in which case their blood pressure is going to be from 90s to 140s? And are they in the vascular phenotype, in which case their blood pressure is going to be more than 140s? So let's talk about each in detail. If the patient has cardiogenic shock, then there has to be early involvement of cardiac ICU and cardiology consult needs to be done. What is the underlying pathophysiology of this cardiogenic shock is important to determine. Is it MI, in which case they need to be taken to PCI immediately? Or is it something like capillary muscle rupture, septal rupture, or any free wall rupture, in which case they need prompt surgical intervention? From ED perspective, in terms of their blood pressure, what we can do is try to give them 200 to 250 mils fluid bolus. If the patient is unresponsive to that, then we have to initiate them on IV vasopressors, which is generally the vasopressor of choice is norepi. Once we get our map where we want to be, we need to start them on inotropic support. Generally, this is provided by either dobutamine or milnirone. Now, remember that inotropes can cause hypotension, and that is why the norepi that we have placed them on needs to be titrated appropriately. But patients that come in true cardiogenic shock are generally not that common. The more common presentation of heart failure is them coming in either cardiac or vascular phenotype of heart failure. If we talk about the vascular phenotype, here the important thing in our management is IV vasodilators that is going to improve both myocardial oxygen supply and demand. So something like nitroglycerin. Now, there are many ways that you can give nitroglycerin. You can give it as a bolus, in which case you will be giving 1 to 2 milligrams, and you can repeat this bolus every 5 minutes. Or you can start them on infusion, in which case the starting dose is going to be around 50 to 100 mics per minute. Now, the important thing to remember about starting them on infusion is that it's not as efficacious as giving them bolus. Obviously, we can also give them sublingual nitro, which in which the dosing is usually 400 mic. But the problem with sublingual is that it needs multiple doses for it to achieve the effect of IV bolus. And obviously, there is oral as well, but oral is generally not advocated for in the ED because it takes a long time to act and is not as efficacious. So, the bottom line and the main takeaway that I want you to take from this is bolus is the best strategy, and otherwise, you can consider starting them on infusion. Now, generally in these patients, there is intercompartmental fluid shift and not really true volume overload. So, you don't have to give them aggressive diuresis, although you can give them a single dose of some sort of a diuretic. Moving on to the cardiac phenotype, and this is where we have intercompartmental fluid shift and also increase in total body volume. And that is why the mainstay of its management is IV diuretic. So we should consider something like IV furosemide, which is very rapid acting and 2 times potent than its oral doses. Now, if a patient is already on a diuretic, let's say the patient is taking furosemide 40 milligrams. So when they come to the ED, the bare minimum that we should do is give them IV 40, but some approaches have recommended giving them 2 to 2.5 times their oral dose. So they would recommend around IV furosemide 80. Regardless of whatever approach you start them on, one parameter that needs to be monitored is urine output. They need to be making that urine because you're diuresing them. But for some reason, if the patient is not producing as much urine as you would anticipate, then there are three things we can consider. Either you repeat the IV dose that you've given them, or you give them an increased IV diuretic dose, or you can also consider to start them on non loop diuretics, so something like IV metolazone. And this basically summarizes the management of heart failure.